Hi class, it's Dr. Balderas. This video is going to discuss pain theories, the gate theory, just some modulation type theories that are out there. There's a lot of new things coming out. I would recommend, as you guys go out to the clinic, that you look at a few of David Butler and Laura Mosley's YouTube and TED Talks. They have a great book called Explain Pain that's really great to use when you're talking to your patients about pain. That has some of the newer theories out there that you won't find in your Cameron book. But today we're basically going to be talking about the basic theories of pain so that you can have an understanding of these physical agents that we're going to be learning about in the next 8 weeks and how they're going to affect that pain from a central nervous system, spinal cord way. This is in chapter 4 as far as your reading goes. So this slide just explains the pain cycle and how it can affect the function of your patient. So you have something that's created your pain that causes some muscle tension in that area, which will then reduce circulation, causing some ischemia in that area, causes some inflammation, which thus then reduces your movement, and that cycle can keep going if we don't break it. So our goal is to break that cycle at some point in there so this just doesn't become a repetitive, recurrent problem for the patient. So these are our objectives for today. The different types of pain that are out there, we will label them they're acute versus subacute versus chronic, the different mechanisms of pain, the gate theory, we talked about pain modulation, measuring pain, assessing pain, and then the management of pain using some of the modalities and physical agents that are available to us. So what is pain? It's that unpleasant sensory and emotional experience associated with an actual or potential tissue damage. So usually it acts as that warning to protect the body from damage. It's our alert system. We have two parts of it. It's the nociception, which is the activation of those peripheral nervous system receptors, obnoxious stimuli, such as we've been using that example of the brick, which is fairly noxious when it falls on you, and that can activate those nociceptive receptors. And sensory experiences, suffering and alterations in behavior. So these are our 3 types of pain. We have acute pain, we have chronic pain, and we have referred pain. Acute pain is caused by that noxious stimulus we talked about, where you get actual or potential tissue damage. The pathology can be identified. It's a protective function, limiting the activity to prevent further damage. So like, when you go and you put your finger and there's that over the stove, or you're out at a campfire and you feel that heat, you pull your hand away in that protective because you feel that heat and that burning and that kind of that pain, and it kind of helps protect that from you. It helps promote tissue healing and recovery. It usually resolves once that tissue damage or threat passes. And it usually lasts less than 6 months in duration, and I would say probably more like 3 months in most cases. There are some types of injuries and post-op surgeries that the normal healing will take about 6 months, so this is why we have this range of less than 6 months duration for acute pain. And before we get talking about chronic pain, I just wanted to clarify that you don't want to confuse your acute inflammatory phase, your subacute or proliferation phase of healing, and your maturation phase of healing with acute and chronic pain. So sometimes when you guys are studying these things, you might get confused when somebody says acute. So make sure you say acute inflammatory phase versus acute pain, because acute pain will last quite a lot longer. We know that acute inflammatory process is done within 6 days. So let's go on to chronic pain. Chronic pain generally continues beyond the duration of that noxious stimuli. It happens to last way longer than normal time for tissue healing. The result, activation of dysfunctional neurological and psychological responses that cause that sensation of pain even when there's no damaging or threatening stimulus is present. I was at a conference at CPTA where Lorimer Mosley was talking about pain, and he used a great example of that person who maybe was walking across the street. The light was green, it turned yellow, it was red right before they got to the crosswalk, and somebody didn't see them and hit them. And so they obviously have an injury that took, in a normal situation, should have taken about 6 months to heal. And this person 2 years later is still having pain. They have this memory, so every time they cross a street, it's an excruciating pain that they get that makes no sense other than that trigger from that light that from when they had gotten hurt. So sometimes it's just a matter of that memory from that injury that we have to work on in a different pathway to try and help them out with that. Then there's our referred pain. And I should go back. Chronic pain usually is anywhere past that normal tissue healing phase. So it can be any time, but normally most tissue heals, like we said, within that 3 to 6 month period. So anything after that is generally labeled as chronic pain. Referred pain is that felt at a location distance from its source. So one joint to another, peripheral nerve to distal area of an innervation, or an internal organ to a musculoskeletal tissue. So we call that like more a visceral referral pattern. So here we have somebody's talking about the heart, and you can see where the heart, which is an internal organ, where it can cause these different areas of referral pain, which means we want to go to the ER, correct? You have the gallbladder, which will give you shoulder pain and sometimes that lateral flank pain. The left ureter will also give you some groin pain. Now, musculoskeletally wise, we also get referred pain. So let's say somebody has pain in their shoulder. They can oftentimes, if it's their rotator cuff or something like that, they'll also get some referral pain down into that anterior deltoid area. Or maybe they have a hip bursitis and they'll get some referral into the groin area oftentimes. So that's referred pain. I think I'm going to stop there for this video, and I'm just going to try and make these into like less than 10-minute videos for you, so you can just kind of watch them at short instances. So the next video we'll start on the mechanisms of pain reduction. Feel free to shoot me an email if you have any questions on this. We'll see you soon.